tachycardia, and then the rest will be involving atrial fibrillation, ventricular tachycardia and the channelopathies, atrial flutter, and then we will go into antiarrhythmic drugs and various device therapy, including the ICD, pacemakers, arrhythmias, and then we'll finalize this block by a discussion of syncope. So we'll start with supraventricular tachycardia. So let's start with this question. A 55-year-old man presents to the emergency department complaining of palpitation that lasts several minutes at a time. He has a history of hypertension, otherwise he is healthy. He admits drinking 2 energy drinks. Usually the energy drinks contain a large amount of caffeine. If a cup of coffee contains something like 60 milligrams of caffeine, then the energy drinks usually contain more than 200 up to 600. So that's sometimes equivalent to 10 cups of coffee. So that is frequently associated with the occurrence of arrhythmia. So he admits drinking 2 energy drinks this morning, and the following strip on telemetry was seen. So have a look on this ECG and I will discuss it. Before going into the questions, let me explain the ECG. The first 2 complexes here are sinus complexes. And then the last complexes here, 4 or 5, is a narrow complex tachycardia. So in between, there is an atrial premature beat located here with a prolonged PR. So what happens here is that the atrial activity goes through the fast pathway in the AV node or around the AV node, and then it excites the ventricle. And then an atrial premature beat occurs. This atrial premature beat will find the fast pathway refractory, because around the AV node in certain individuals we have a dual pathway, a fast pathway with sodium conduction and a long refractory period, and a slow pathway with slow conduction because of the lack of the sodium channels, and at the same time the duration of the action potential is short, so the refractory period is short. So if the fast pathway conducts, the PR segment here is narrow, is small, and then a premature beat occurs, it gets blocked into the highly refractory fast conducting pathway. It conducts through the slow pathway, and as a result of that, the PR interval gets prolonged. And then when it reaches the slow pathway back to the atrium, it finds the fast pathway recovering from refractoriness, so it excites the ventricle again. So at the same time, this gets repeated. If it occurs once, that's an echo beat. If it occurs twice, that's a couplet. If it occurs repeatedly more than 3 times or more, that's supraventricular tachycardia. So this is the underlying mechanism of this simple ECG. So going from that into the question, what is the most likely mechanism of this tachycardia? Is it a typical AV node reentrant tachycardia, or typical AV node reentrant tachycardia, or orthodromic AV reentrant tachycardia, or antidromic AV reentrant tachycardia, or atrial tachycardia? Of course, that's the correct answer is B. It's a typical AV reentry tachycardia, because as I explained, the atrial activity changed its mind. Instead of conducting like normal in the fast pathway with a long refractory period, it conducts into the slow pathway, because a premature beat will find the fast pathway refractory, and then it goes back to the atrium, excite the atrium, and then down the fast pathway, which is now recovered. Now this is very important, because this is one of the most common supraventricular tachycardia. As a matter of fact, the 3 important types of supraventricular tachycardia, the atrial tachycardia accounts for almost 10% of supraventricular tachycardia. If we know the reentry tachycardia accounts for 60%, and the remaining 30% is AV re-entry tachycardia. Atrial tachycardia usually has a long RP, and I will explain that shortly. And the mechanism is usually abnormal automaticity. Sometimes it's due to micro re-entry, and sometimes it's due to triggered activity. And usually the foci, which is responsible for atrial tachycardia, is located around natural holes or natural defects, like the tricuspid annulus, the mitral annulus, the pulmonary veins, the crista terminalis, or the coronary sinus. In AV nodal re-entry tachycardia, this is two types. The typical one is associated with a short RP tachycardia, and I will explain that. And the atypical is a long RP tachycardia, and this is due to re-entry around the AV node. Remember that the AV node does not contain the circle which is responsible for the supraventricular tachycardia. It's the region of the AV node. So if you hear me talking about the AV node, you would think of the AV nodal region, not the spot which is called an AV node, because actually the fast pathway and the slow pathway are not located in the AV node, they are located around it. And it is important to realize that this is a physiological concept, and the concept has been verified by electrophysiological studies, but histologically, nobody could identify something called a fast pathway or slow pathway. So we have nothing in terms of histology, so we don't know exactly where they are located. Probably they are not located anywhere. It's a physiologic disturbance, and the concept is correct because it's supported by all electrophysiologic studies that have been carried over the last 3 decades. In AV re-entry tachycardia, this is a tachycardia which is associated with the presence of an accessory pathway. If the atrial activity goes down the AV node and up the accessory pathway, we call it orthodromic or short RP tachycardia. It's ortho in relation to the AV node. So it goes down the AV node and it goes up the accessory pathway. If it goes in the reciprocal way down the accessory pathway and up the AV node, we call it antidromic AV re-entry tachycardia. There is another AV re-entry tachycardia called the paroxysmal juncture reciprocal tachycardia. It's a misnomer, and this paroxysmal juncture reciprocal tachycardia is actually an orthodromic tachycardia. And this orthodromic tachycardia is associated with conduction down from the atrium to the ventricle across the AV node, and then a posteriorly located long decremental pathway posterior to the septum back to the atrium. This is the paroxysmal junction reciprocal tachycardia, or Comel and bent tachycardia. It's a long RP tachycardia, so it's where the PGRT or paroxysmal junction reciprocal tachycardia has nothing to do with the junction. It's a form of orthodromic reciprocating tachycardia. محمد، في صوت مع كل واحد بيخش بيضرب عندي جرس هنا، هل ده ممكن يتشارك؟ في جرس بيضرب عندي كل واحد بين الجروب بيضرب تك كده اهو، ده لبخني شويه، فاذا كان ممكن نتشال يبقى احسن. طيب حاضر، اشوف لو هيتشال هشيل. Okay. Now let's go to the explanation of the short versus long RP tachycardia. If this is the RR interval, then you divide this distance into half. If the P wave falls into the left-sided half, this is called a short RP tachycardia. If the P wave falls into the right-sided half, it's called a long RP tachycardia. So, for example, this is the R wave, and this is the P wave falls to the left of the middle line. So this is a short RP tachycardia. On the other hand, this P wave falls to the right of the middle line, so it's called a long RP tachycardia. And this is the only classification available for supraventricular tachycardia. The main differential diagnosis of short RP tachycardia is a typical AV nodal re-entry tachycardia, in which the atrial activity goes down the slow pathway and goes up the fast pathway, so it's a slow fast atrioventricular nodal tachycardia, the orthodromic AV reentry tachycardia, in which the atrial activity goes down the AV node and up the accessory pathway, and sometimes atrial tachycardia if it is associated with first-degree heart block. Long RP tachycardia, on the other hand, is a usual thing with atrial tachycardia without heart block. The atypical AV nodal reentry tachycardia, in which atrial activity goes down the accessory pathway and up the AV nodal pathway, and the PGERT, which is paroxysmal juncture reciprocating tachycardia, which, as I just said now, is a form of orthodromic AV reentry tachycardia with a slow conducting posterior septal pathway. Now, if you look to this electrocardiogram, this is a typical form of a atrial tachycardia. It should be recognized because if it is missed as sinus tachycardia and not treated, it will end up with cardiomyopathy. So this is an important thing. And as you see here, it's a narrow complex, narrow QRS complex tachycardia. But the important thing is that the P wave axis is abnormal. The P wave here is inverted in the inferior leads. And if you look to the magnified electrocardiogram, it's inverted in the inferior leads. So it means that the focus of atrial activity is located down in the atria. At the same time, it is positive in V1. Usually the P wave is either biphasic or more commonly negative in V1 because the sinus node is located in the right atrium, which is an anterior structure, and activates the atrium in an antero-posterior direction. So as a result of that, a sinus P wave is negative in V1 and is positive in the inferior leads. And as you see here, the sinus, this is not sinus because it is positive in V1 and is negative in the inferior leads. So the most likely thing, if it is positive in V1, it's arising from the left atrium, a posterior structure, and moving anteriorly towards the right atrium, over which is located the V1 electrode. And at the same time, it's coming from below upwards. So the most likely origin of this atrial tachycardia is from the right inferior pulmonary vein, where the inferior pulmonary vein is located in the left atrium, so it activates the atrium in a posterior anterior direction, and at the same time it's located down, so it activates the atrium in an infero superior direction. It can be located as well into the body of the coronary sinus, which is located behind the left atrium. So as you see in atrial tachycardia, it should be recognized because otherwise you might diagnose it as a sinus tachycardia. It's an incessant tachycardia. Usually it is not very rapid, and as a result of that, many patients do not complain of anything and they present with cardiomyopathy. And it's usually a long RP tachycardia. As you see here, RP is long. It's rarely associated with a short RP tachycardia. Under these circumstances, the atrial tachycardia will be associated with first-degree AV block, which results in prolongation of the PR interval and the shortening of the RP interval. So how you treat atrial tachycardia? If the patient is hemodynamically unstable, you cardiovert. Sometimes you give adenosine given at 6 milligrams intravenous bolus with flush. Everything otherwise from the antiarrhythmic drugs should be given slowly. The only antiarrhythmic drug which should be given rapidly is adenosine because it's there. Usually it's metabolized by the red cells and might not reach the heart if it is given slowly. So 6 milligram, if it doesn't work, 12 milligrams can be repeated twice after a few minutes. If the patient is quite unstable, then cardiovert. If the patient is not responsive to cardioversion or adenosine, you can use beta blockers, diltiazem, and verapamil. The trick here is that these drugs are effective, but the important point, they should be given in small doses and they should be given slowly. Otherwise, you will end up with hypotension, sympathetic stimulation, and the aggravation of the tachycardia. If this is not working, we move to class 3 antiarrhythmic drugs, essentially intravenous amiodarone or ibutylide. So as you see in most of the supraventricular tachycardia, which we'll spend today discussing them, we move from adenosine, which is usually the drug of choice in the acute events, sometimes cardioversion, if the patient is presenting with pulmonary edema, chest pain, hypotension, the drowsiness or any hemodynamic disturbance. And then if they don't work, we go to the calcium antagonists or the beta blockers, and then we leave the class 3 antiarrhythmic drugs until the end. As you see here, we don't find 1C because 1C is not usually used in patients with structural heart disease, and the large majority of patients with atrial tachyarrhythmias, atrial tachycardia is associated with organic heart disease, so AC should not be used. So for chronic management, catheter ablation is the first choice. Although the success rate is not as large as with AV nodal re-entry tachycardia, neither with AV re-entry tachycardia, but the success rate is still in the domain of 80%, and the complication rate is usually within 1 to 2%. One important complication here is that the need for using anticoagulant if you are working on the left side of the heart, so bleeding for vascular access and hemopericardium can occur. If the patient is not the candidate for ablation for some reason or the other, or if he's refusing ablation, then you can use beta blockers or calcium antagonists. If not, and the patient is free of structural heart disease, you use 1C drug, propafenone or flecainide. Remember the CAST study, AC is not IC, or the group 1C drug should not be used in patients with structural heart disease, and the structural heart disease include ischemic heart disease, severe valvular heart disease, cardiomyopathy, or congenital heart disease. If nothing of this is working, then you are forced to go to SAD. And SAD is the abbreviation of sotalol, amiodarone, and the dofetilide. Remember, dofetilide in the last atrial fibrillation guidelines of the ECC has been removed totally, but the American guidelines is still retaining it, and we will be discussing that in the antiarrhythmic drug. Now we go to the commonest type of AV nodal re-entry tachycardia, and as I told you, the region of the AV node is not the spot which we call the AV node. And this region of the AV node, some people, at least a good percentage, 40–50% of normal individuals, they have a fast conducting pathway with a long refractory period and a slow conducting pathway with a short refractory period. بالنسبة للناس الجداد عشان ما يبقوش confused، الفاست باثواي ده عباره عن ايه اللي بيخلي الكوندكتنج رابيدلي؟ phase zero. Phase zero is sodium channels. So if you have enough sodium channels, that will ensure fast conduction. Now the refractory period has nothing to do with the sodium channel. It has to do with the duration of the action potential, essentially the potassium channel and the calcium channel. And as a result of that, if you prolong the action potential, you get a longer refractory period. So the fast pathway has a lot of sodium channels, so it's fast conducting, has a prolonged QT interval or prolonged refractory period, prolonged action potential, and as a result of that, it's under normal circumstances, the impulse comes from the atrium, conducts through the fast pathway, and reaches the ventricle. But if the fast pathway cannot conduct the impulse because it is premature, and because of its long refractory period, it blocks the premature beat, then the premature beat will conduct through the slow pathway. It's slow conducting because it's full in sodium channels, but it has a short refractory period because the action potential duration is short. So it conducts in the slow conducting pathway down to the ventricle to activate both ventricles. By that time, the refractory period of the fast pathway will be recovering. So the impulse, in addition of going down to the ventricle, it goes as well up to the fast pathway to activate the atrium. If that occurs once, that's an echo beat. If that occurs twice, that's a couplet. If that occurs thrice or more, that's a supraventricular AV nodal re-entry tachycardia. Now concentrate on this point. If the impulse reaches this point through the slow pathway, then it has to move in one of two directions, either up through the fast pathway or down to activate the ventricle. And under these circumstances, you can imagine the activation of the atrium will occur simultaneously with the activation of the ventricle. And so therefore, the retrograde P wave will be embedded into the QRS complex. So imagine that this point is a fulcrum, and this fulcrum, the P wave coming from the slow pathway will reach this fulcrum, and then there is a race between the backward conduction through the fast pathway to activate the atrium and the forward conduction through the ventricle to produce the QRS. So sometimes the P wave appears immediately after the QRS, and sometimes appears immediately before the QRS. So sometimes it produces a pseudo Q wave if it appears before the QRS, or it produces a pseudo R prime wave if it appears after the. This is important. So in the fast pathway, this is the normal conduction of the atrial activity. The slow pathway gets activated if there is a premature beat cannot pass through the fast pathway. So this is what happens in AV nodal reentry tachycardia. If you look to the magnified, this is the QRS complex, and this little glitch, this notch, is actually the retrograde P wave. And as I told you, after reaching the fulcrum, the P wave will go from below upward to activate the atrium, and the QRS will go from above downwards to activate the ventricle. If the patient goes into sinus rhythm, this little glitch disappears. You don't find it here. So the P wave activation here is at the heel of the QRS activation. Sometimes in the inferior leads, it appears to be even before the QRS. So it appears as a pseudo Q wave. So it's very important to realize that the PR interval here is very short and is usually less than 70 milliseconds. So remember the figure 70 milliseconds. 70 milliseconds is the distance between the beginning of the QRS and the beginning of the retrograde P wave. This means that the atrium and the ventricle are almost simultaneously activated together. And as a result of that, the P wave will appear at the end of the QRS, giving an impression of an R prime at the heel of the QRS, and even sometimes it precedes the QRS. This is supplemented by the intracardiac tracing. So as most of you now acquainted with this kind of tracing, this is the compressed standard leads, the lead 1, AVL, AVF, V1, and V6. And then we have a high right atrium electrode, and then we have the His bundle electrode, and then we have the ventricular electrode. And as I always say, go from what you know to what you do not know. So this is red deflection is a ventricular activation because it is coinciding with the QRS complex, and the His bundle deflection is in the His bundle lead. So if you see here, the His bundle gets affected. This is a fulcrum point. This is the fulcrum point. The His bundle gets affected and gets activated. And then from the fulcrum point, retrograde activation occurs and produces the atrial signal, and anterograde activation goes to the ventricle to produce the ventricular signal. So although we do not have any histologic evidence of the existence of what is called fast or slow pathway, we have an electrophysiologic support for the concept. So it stood the test of time. It agrees with the electrophysiological explanations, and so it's an accepted theory. We don't know that why some people have a dual AV nodal conduction system but do not get an AV nodal reentry tachycardia. This is still some point under research. Nobody can answer this question at the present time. So back to the original tracing, this is a sinus wave conducting through the fast pathway. This is a premature atrial wave conducting through the slow pathway, a premature atrial wave conducting through the slow pathway, and then after getting into the ventricle, activates the ventricle and back to the atrium. Activates the ventricle and back to the atrium. This is not an S wave. This is the embedded P wave with retrograde activation of the atrium. So this is an AV nodal reentry tachycardia, the so-called fast-slow conduction, or the typical AV nodal reentry tachycardia. Now, in the acute management of these patients, vagal maneuvers, the best is straining for 10 seconds. The European guidelines recommend the carotid sinus massage, provided that the patient is supine, there is no murmur or evidence of recent stroke or transient ischemic attack. And they add one peculiar something is that you should elevate the legs of the patient somehow to increase the venous return and guard against the occurrence of hypotension. If the vagal maneuver doesn't work, the drug choice is still class 1 indication is adenosine in the way we described. If the patient is hemodynamically unstable, cardioversion. If the adenosine didn't work or contraindicated because the patient is asthmatic or having some form of conduction defect, or he has been receiving a Perzantine or caffeine or theophylline within the past half an hour, then intravenous beta blocker, diltiazem or verapamil, in contrast to the rapid injection of bolus adenosine. These drugs, which are beta blockers and calcium antagonists, should be given slowly to avoid hypotension. If you get hypotension, you are in trouble because they will aggravate the tachycardia through sympathetic stimulation. If pharmacological therapy fails, then we go to cardioversion, and then a last resort will be intravenous amiodarone. Remember that the sorbitrate, which is the solvent amiodarone, can aggravate hypotension in these patients. If the patient is at home, and then he can use a large dose of beta blocker, diltiazem or verapamil. So it's the same concept, whether we are dealing with AV nodal reentry tachycardia or atrial tachycardia, or as we are going to describe shortly, AV reentry tachycardia. We go from adenosine to beta blocker and calcium antagonist, 1C, and then class 3 antiarrhythmic drugs in that order. For chronic management, if the patient is getting short episodes of tachycardia every few months, then just the surveillance is enough. Don't go to pharmacologic long-term chronic pharmacologic therapy, and don't advise ablation, because still ablation, although very, very, very successful with the low complication rate, but it's an invasive procedure. If the patient can tolerate the attack, it occurs once for a few minutes every 6 months, leave him. If not, then the patient, the class 1 recommendation is catheter ablation, because most of these patients are young, healthy persons, so you don't like for them to remain for lifelong on antiarrhythmic drugs. So catheter ablation, you ablate the slow pathway. Unfortunately, we don't have the blackboard, which we are accustomed to during the hospital classes. But if you imagine the triangle of Koch, or Koch's triangle, the Koch's triangle is a triangle located on the right side of the atria and the right side of the atrial septum. The base is the coronary sinus. The apex is the AV node itself. The lower side of the triangle is the base of the septal leaflet of the tricuspid valve, and the upper side of the triangle is the tendon of Todero. The tendon of Todero is the part corresponding to the bulge of the aortic sinuses into the right atrium. Now, the slow pathway is in the base of this triangle, going from the coronary sinus to the AV node adjacent to the septal leaflet of the tricuspid valve. Then we put the catheter near the coronary sinus and we ablate at this area, far away from the AV node. You need a wide area of ablation because the fibers here are widely separated. They converge towards the AV node. The success will be more if you ablate towards the AV node, but the risk of AV block will be higher. So the electrophysiologists usually try to play on the safe side, ablate near the coronary sinus away from the AV node, although that takes some time of it. Rate of success with ablation is very high, above 95%. Complications rate is 3%, and the patient should understand that he rarely needs a pacemaker. Less than 1% will be candidate for pacemaker implantation. Beta blockers or verapamil are indicated if the patient refuses ablation or ablation didn't work, which occurs usually in 3 to 4% of patients. If the patient doesn't have structural heart disease, then 1C, flecainide, and propafenone. If nothing works, then we go to SAD, which is sotalol, dofetilide, and amiodarone, and rarely is digoxin used for that reason, almost never. Now we move to the third type of supraventricular tachycardia, which is AV reentrant tachycardia. As I said, two types: orthodromic, in which the impulse goes down the AV node through the fast pathway, activate the ventricle, and then up the accessory pathway. The accessory pathway is located anywhere around the mitral valve, mitral ring, or around the tricuspid ring, and usually goes from the corresponding ventricle to the ipsilateral atrium. If the accessory pathway conducts only retrogradely, this is called a concealed accessory pathway, because there is no delta wave under normal circumstances in sinus rhythm, but the impulse goes from the through the AV node by conducting atrial activity in an orthodromic fashion, activates the ventricle, and then passes retrogradely across the AV node accessory pathway to the atrium. If the accessory pathway conduct anterogradely, then the impulse can go down the accessory pathway. Under these circumstances, the patient will have a delta wave in sinus rhythm, so you know that he is having a manifest, not a concealed accessory pathway. It conducts down the accessory pathway and up the AV node. This is antidromic. The orthodromic, ortho in relation to the AV node, is characterized by a short RP tachycardia. So under these circumstances, the ventricle gets activated here, and after the ventricle gets activated, the atrium gets activated. This is still a short RP, but as you see, the distance between the R and P will be longer than in AV nodal reentry tachycardia, will be more than 70 milliseconds. So 70 milliseconds and below fevers AV nodal reentry tachycardia, 70 seconds or more in favor of AV reentry tachycardia. Why is that? Because here the impulse has to go and traverse the ventricle all the way to the accessory pathway, which may be located far away from the left lateral side of the mitral annulus, and then activates the atrium. So that takes some time and produces a relatively long RP. Still, the P wave is in the left-sided half of the RR interval, so it's counted as a short RP tachycardia. So the P wave here falls into the ST segment. One important pair: if you have an AV, a supraventricular tachycardia, and the supraventricular tachycardia looks from being short RP with the SP wave falling in the ST segment, looks at an AV reentry tachycardia, and then the patient develops a bundle branch block aberration. And with the development of bundle branch block, the tachycardia slows down. Now this tells you two things. Number one, that this is true AV reentry tachycardia. Number two, that the accessory pathway is on the same side as the interrupted bundle branch. Let me explain that. Under normal circumstances, look at the left-sided figure here. The impulse here comes from the atrium and activates the right and left bundle branch block, right and left bundle branches, and then goes retrogradely through the accessory pathway to activate the atrium again through the accessory pathway. Now suppose that we got a right bundle branch block here. So the impulse will come from the atrium, then it will activate the left bundle, has to cross through the left ventricle, across the interventricular septum to reach the right ventricle, and then through the accessory pathway goes to the atrium. So it takes a longer cycle. So the cycle length will be longer and the rate will be slower. So if you get an accessory pathway conduction, an AV reentry tachycardia, and a bundle branch block, which is common because of aberrancy due to the accelerated heart rate, and the bundle branch block results in slowing of the rate of the tachycardia, then this confirms an AV nodal reentry, AV reentry tachycardia, and it tells you that if you have a right bundle branch block, the accessory pathway will be on the right side. If you have a left bundle branch block, the accessory pathway will be on the left side. So this is an important pair which helps the electrophysiologist to localize the location of the accessory pathway. And this is the intracardiac tracing. And as you see again here, the standard leads, which are usually compressed. You have a high right atrial electrode, you have a His bundle electrode, then you have a coronary sinus electrode, a Deca electrode. The coronary sinus 1 to 2 is in the distal coronary sinus across the mitral ring, and then proximal coronary sinus usually coronary sinus 5, 6, 7, 8, and 9, and 10. And then we have in the red here ventricular activation, and again go from what you know to what you do not know. So this is the QRS complex. It goes with the ventricular activation, and this is the atrial activation here, goes with the P wave here. And as you see here, if you start with the atrial activation here, the impulse will conduct through the blast pathway to activate the ventricle, and then will go from the ventricle through the accessory pathway, and then will go back to activate the atrium. Now, where in the accessory pathway, the earliest point of activating the ventricle here is in the distal coronary sinus 1 and 2, which is distal coronary sinus opposite the lateral mitral ring. So this tells you that you are dealing with an intracardiac tracing of orthodromic AV re-entry tachycardia, and the location of the accessory pathway is in the lateral mitral ring. And as you see here, the P wave corresponds to QRS, the ST segment here, and is located away from the QRS complex by more than 70 milliseconds. So this supports the impression from the electrocardiogram by electrophysiologic study. Simple, straightforward, and very informative. Now again, the treatment in the acute stage, vagal maneuvers, as we alluded to, adenosine, if hemodynamically unstable cardioversion, then if nothing of this works, then we go to calcium antagonists and IV beta blockers. Now it's important to know that these three drugs carries the recommendation of 2A and 2B. What determines that? If the patient is not pre-excited in sinus rhythm, the accessory pathway conducts only retrogradely, doesn't conduct anterogradely. So this means that it is a safe accessory pathway. If atrial fibrillation occurs, it doesn't conduct to the ventricle and produce ventricular fibrillation. So under these circumstances, if we block the AV node, the accessory pathway will not conduct the sinus impulse. So as a result of that, it is labeled the 2A. But if the accessory pathway conducts a sinus impulse, that is to say, the sinus electrocardiogram has a delta wave, then under these circumstances, you can still use these three drugs, but it carries the concept of class 2B recommendation. If nothing pharmacologically works, then you have to revert to cardioversion to abort the arrhythmia. So that's for acute treatment. For chronic treatment, again, ablation. Ablation, it's easy, it's rapid, it's effective, and is long-lasting. Overall success rate approaching again 95%. Complications is again about 3%, and the tamponade can occur if you are working on the left side of the heart because of anticoagulant use. If the patient refuses or he is not candidate for ablation or ablation failed, then you go to the three drug combinations, beta blockers, diltiazem, and verapamil. Again, it's a class 1 indication if there is no delta wave in the sinus electrogram. It is 2B if there is a delta wave, because as I said, if you have the sinus impulse conducting anterogradely through the accessory pathway, this is a dangerous situation because when atrial fibrillation occurs, which is a common occurrence in patients with accessory pathway, and this will result in ventricular fibrillation, quite undesirable situation. If this didn't work and there is no structural heart disease, as we pointed out previously, you use 1C drug, plecanide or propafenone. If nothing works, then go to class 3 drug. Same concept, same orders. Digoxin is not used in patients with pre-excitation, not only because digoxin impairs AV conduction, but it shortens the refractory period of the accessory pathway. Remember, both digoxin and amiodarone. Previously, we were using amiodarone in patients with accessory pathway. No longer. The international guidelines is consistent about this point, that amiodarone shortens the effective refractory period of the accessory pathway, so it enhances the conduction across the accessory pathway. We go to unusual forms of supraventricular tachycardia. We talked about the typical AV nodal re-entry tachycardia going down the slow pathway and up the fast pathway. Now we have the opposite, going down the slow pathway and going up the fast pathway. So if you see here, this will result in a long RP tachycardia. The impulse will go down from the slow pathway, and as a result of going down from the slow pathway, it goes a long interval until we get activation of the atrium, and then up the fast pathway and activates the ventricle. So it results in a long RP tachycardia in contrast to the typical AV nodal tachycardia. So this is a fast, slow tachycardia in contrast to the slow, fast AV nodal re-entry tachycardia, with the fast, slow, long RP with the slow, fast. Sometimes you get the P wave exactly in the middle. So this is usually very rare, and it gets confused with atrial flutter, but usually it gets explained by a presence of a slow conduction, two slow pathway, or one slow and another one which is intermediate, neither fast nor slow. But this is usually left for the electrophysiologist to discuss it. Now, with PJERT or paroxysmal junction reciprocating tachycardia, as I said, this is an accessory pathway which is slowly conducting, and it's connected between the left ventricle and the left atrium, posterior to the interventricular septum. It shows decremental conduction like the AV node. If you stimulate the ventricle rapidly, then you get weakening of and lack of conduction across this accessory pathway. So this is a Kummel pathway or Kummel-Bennett pathway. It's an orthodromic AV re-entry tachycardia. It's not common, but because it's not rapidly conducting and the rate is not rapid, the patients usually are asymptomatic and they present with cardiomyopathy. If you detect it and you ablate the slowly conducting decremental accessory pathway, you get rid of the cardiomyopathy. And the third unusual form of supraventricular tachycardia produces a wide complex tachycardia, which is antidromic AV re-entry tachycardia. The impulse conducts down the accessory pathway to activate the ventricle and upward the AV node, so it produces a wide QRS tachycardia, one of the differential diagnoses. Obviously, if you have a heart disease, then most likely ventricular tachycardia, wide QRS tachycardia is ventricular tachycardia. If you don't have a heart disease, then you might think of different possibilities. One of them is antidromic AV re-entry tachycardia. Now, junctional tachycardia, another form of supraventricular tachycardia, quite rare in adults, usually seen in children, usually seen in the post-operative state after open heart surgery in infants and the children. In adults, usually you need to exclude every other possibilities, and most of the patients diagnosed as junctional tachycardia by the computer turn out to be an unusual form of AV nodal re-entry tachycardia. It comes in two flavors: paroxysmal, which is usually due to abnormal automaticity in the AV node or the bundle of wrist. These are usually adult patients in the CCU with sepsis, catecholamine infusion because of hypotension, and the high adrenergic state enhanced the automaticity and produced the paroxysmal junctional automatic tachycardia. Or non-paroxysmal, the classic situation for that is digitalis toxicity, but it can occur also in patients with acute myocardial infarction, and it can be due to enhanced automaticity or triggered activity, as we alluded to in the previous year. We'll discuss that again. Now, the last thing you think about in the treatment of this condition is to try to ablate the junction. If you treat to ablate the junction to get rid of the tachycardia, then most likely you are going to complete heart block and the patient will be totally pacemaker dependent. So the treatment here is treatment of the underlying etiology, aborting the adrenergic state which is present, getting rid of digitalis toxicity, treating the myocardial infarction, or treating the post-operative state in infants or children with this tachycardia. Now, how you localize the accessory pathway? The most valid method is the Aruda-Jackman algorithm. It's a complicated algorithm used by many electrophysiologists. You need to remember it, but anyhow, it's cumbersome, and all the method, all the algorithms are just an approximation. Actually, you cannot localize the accessory pathway unless you get full activation of the accessory pathway. So you get a very prominent delta wave to know the axis. This is not available most of the time. But this is one of the simplest algorithms which is recommended by the American College and the American Heart, and it needs you 2 steps. The first step is to look for the QRS complex in V1. If V1 is right bandyloid, right bundle branch block pattern, that's a tall R in V1. This means that the accessory pathway is left-sided. If it is left-sided, then it will activate the ventricle from posterior to anterior, and it will be positive in V1. If it is negative in V1, looks like a left bundle branch block pattern, then it is right-sided. If it moves from negative to positive between V1 and V2, it's located in the center. So looking at V1 will let you categorize the patient either in the left side, if it's right bandyloid, on the right side, if it is left bandyloid, or if it jumps from V1 negative to V2 positive, then it is center. And the next step is to look into the inferior leads. If the inferior leads 2, 3, and the AVF showing a positive delta wave, a positive complex in 2 of the 3 leads or more, then it's anteriorly located, activating the ventricle from above downward. And if it is negative in the inferior leads, it is inferiorly located. So as you see here, this is the mitral annulus, this is the tricuspid annulus, and the accessory pathways are located around this. The commonest is at the lateral mitral annulus, then the posterior mitral annulus, then the septal, and then on the right side. And if you get a V1 negative complex, this means that the delta wave is located here, the accessory pathway is located on the right side. If it gets positive, it's located on the left side. So by looking into the precordial leads of V1, essentially, you can localize right or left-sided, and then looking in the inferior leads, it tells you whether it is in the superior mitral or the tricuspid valve, or in the inferior mitral or the tricuspid valve. In the superior, it will be positive in the inferior leads, and vice versa if it is in the inferior mitral or tricuspid valve. Simplification, but it works in the large majority of cases, saves you the trouble of remembering the Jackman-Aruda algorithm. Now, knowing that, let's answer this question. In which region you will expect the accessory pathway? Look at the electrocardiogram. Is it right posteroseptal, right anteroseptal, left posterior, or left anterolateral? Now, if you look here, V1, it's positive. So if V1 is positive, it must be from the left side of the heart, from the left ventricle. So it's located on the left side. Is it superior or inferior? Look at the inferior leads, and in the inferior leads, it is positive here. So as a result of that, it's on the left side, but it's anterior. Now, if you look into AVL, it's negative in AVL. So it's moving away from AVL. So it's left-sided, it's anterior, and is lateral. So it moves away from AVL. So correct answer will be left anterolateral. Now this will be amplified here. This is the mitral valve, this is the tricuspid valve, and the location of the accessory pathway here is located in this area. So if it's located in this area, it will be moving towards this side away from AVL, so it will be negative in AVL. At the same time, it's slightly anterior, so it will be raining down, so it will be positive in the inferior leads. And since it is on the left side of the heart, it will produce a right bundle branch morphology. So the correct answer here would be a left anterolateral location for the accessory pathway. Now we have we have many actually, but the 2 important unusual accessory pathway is the Mahaim pathway, rare but important to recognize, and then the posteroseptal decremental pathway, which is responsible for the paroxysmal junction reciprocating tachycardia that we were pointing to just shortly. So what's the Mahaim pathway? The Mahaim pathway is actually another AV node located in the wall of the right atrium, and it goes from the right atrium across the tricuspid ring to the right ventricle to be connected to branches of the right bundle. So under normal circumstances, you don't get a delta wave, although there is an accessory pathway. And this Mahaim pathway conducts only anterogravity, doesn't conduct retrogravity. So the delta wave is either very small or almost absent. So the impulse here conducts through the AV node and the Mahaim pathway, which acts as another AV nodal pathway. If you pace the atrium, you will get progressive conduction delay across this pathway because, like the AV node, it shows decremental conduction. Now, this accessory pathway, as I said, crosses across the tricuspid valve, and it goes to insert into a fascicle from the left bundle, or for the right bundle. If you pace it, then you get a left bundle branch block pattern. If the patient gets tachycardia by passing it down the Mahaim pathway, it activates the right ventricle first, so it produces a left bundle branch block tachycardia, and since it activates the right ventricle from the lower side, since it's inserted in the distal right bundle, it produces a left axis deviation. So if you find a wide QRS tachycardia, taking the morphology of left bundle branch block and a left axis deviation, think of Mahaim in addition to other things. So obviously the treatment for this condition will be ablation of the Mahaim pathway. Now don't mistake it for ventricular tachycardia. And this is the second unusual form of accessory pathway which produces decremental conduction. Usually the accessory pathway do not produce decremental conduction except under these two circumstances. And decremental means that if you accelerate the impulse passage through the pathway, it decays. It produces a Wink-Bach conduction, and then it stops conducting altogether. And this accessory pathway is located, as I mentioned before, in the posterior septum, going from the left ventricle to the left atrium, and it produces paroxysmal junction reciprocating tachycardia down the AV node, and then activating the ventricle and upward through this retrograde, slowly conducting decremental pathway. And as I said to you, this is not a rapid tachycardia. It decays with time, but it persists enough to produce cardiomyopathy. And if you don't detect it, you cannot treat the situation. Question 4. A 45-year-old man presents to the emergency department with dizziness and palpitation after all you can eat buffet. He has not seen a doctor for the last 20 years. He is not in distress but anxious. Vital signs: blood pressure 100/70 millimeters of mercury and pulse 107. And this is the electrocardiogram. Obviously, most of you will recognize it. This is a wide, complex tachycardia, but if you see it, it's quite irregular, not only in the RR interval, but in the width and the morphology of the R wave or the QRS complex. So this is typical of atrial fibrillation, which occurs in patients with anterogravely conducting accessory pathway. This is a pre-excited atrial fibrillation. If you don't detect it, it degenerates into ventricular fibrillation and death. So it's very important to be detected. Any patients with left bundle branch block at a very rapid rate, variability in or irregularity in the rhythm and irregularity in the morphology of the QRS complex, particularly in young age, think of pre-excited atrial fibrillation. So the question is, what's the next step in the management? Adenosine, butylide, diltiazem, 8-metoprolol, or amiodarone. The correct answer is butylide, class 3 antiarrhythmic drugs, given as 10 milligram, 1 milligram over 10 minutes. You wait another 10 minutes. You can repeat 1 milligram over another 10 minutes. Very effective in blocking the accessory pathway. Adenosine is absolutely contraindicated because it blocks the AV node, has no effect on the accessory pathway. It enhances the conduction through the accessory pathway, so the rate of ventricular activation will increase. Same applies to diltiazem, metoprolol. Amiodarone will shorten the refractory period of the accessory pathway, so it's absolutely contraindicated. Previously, we were treating these patients with amiodarone, and we were getting into troubles because of that. The new guidelines is clear about that. The treatment of the choice is abutalized. Procainamide can be a substitute, but usually it's not available. So pre-excited atrial fibrillation looks like ventricular tachycardia, but it's too irregular. If the RR interval, the distance between the shortest RR interval, less than 250 milliseconds, then you worry about this, because this is the kind of patients which activate the ventricle very rapidly and produces ventricular fibrillation and death. Acute management is cardioversion. If the patient is stable and you have an access to abutalized, give abutalized or procainamide. Unfortunately, both of them are not available in Egypt, so the only available treatment for these patients, whether they are stable or unstable, is immediate cardioversion. Don't use IV digoxin, don't use IV amiodarone, because these two drugs will facilitate the conduction through the accessory pathway, since they shorten the refractory period of the accessory pathway. And don't use these three beta blockers, diltiazem and verapamil, because they block the AV node, and hence all the impulses coming from the atrium, where atrial fibrillation will be forced through the accessory pathway and produce ventricular fibrillation. So this simplifies the concept of avoiding beta blockers, verapamil and diltiazem, since they block the AV node conduction and facilitate the conduction. They block the AV node conduction and facilitate the conduction through the accessory pathway. Why they facilitate? For two reasons. Number one, if you give them intravenously, they drop the blood pressure. If you drop the blood pressure, you activate the sympathetic nervous system, and this shortens the refractory period of the accessory pathway and enhances the conduction. But there is another point, another reason also for not blocking the AV node. If you block the AV node, then no impulse will come through the AV node. If it comes an impulse through the AV node, it goes retrogradely and poisons the accessory pathway, blocks the conduction through the accessory pathway. So if you block the AV node by diltiazem, verapamil, or beta blockers, you prevent this poisoning, and this facilitates the conduction across the accessory pathway. You don't use digoxin and amiodarone, since this will also shorten the refractory period of the accessory pathway. So all of these drugs are commonly contraindicated under this circumstance. I assure you that you will encounter in your practice frequently this situation, and I assure you that one of the questions in any examination, multiple choice questions, will contain something related to this part. So what to do for patients with asymptomatic WBW? This is controversial, but this is important. We have three pathways by which we can behave in this condition. Usually, if the patient is asymptomatic and having delta wave in the ECG, he doesn't have WBW syndrome. Syndrome means he's developing tachycardia and symptoms. He is having the WBW pattern. Delta wave, short PR, wide QRS complex in the ECG. Then you watch the patient. If the patient on the Holter monitor or the exercise test, the delta wave disappears suddenly, it means that it's a weak accessory pathway, so you leave the patient alone. If you are not sure, then you can study the patient by electrophysiological study, induce atrial fibrillation, measure the RR interval. If it is less than 250, the accessory pathway should be ablated, because the patient may get ventricular fibrillation because of the rapid conduction of atrial fibrillation. Or you measure the effective refractory period of the accessory pathway, and the figure is close to 250, it's 240. Either of these situations is a class 2A indication for ablating the accessory pathway. If the patient is asymptomatic but is in a risky job, is a pilot, is working in the military, is driving a public carrying the vehicle, then under these circumstances, based on the risky situation of this job, you can ablate the accessory pathway. So usually we leave them alone unless there is an evidence of rapidly conducting accessory pathway or a dangerous job under this circumstance to a bleeding. We leave supraventricular tachycardia and we move to a situation closely mimicking supraventricular tachycardia, extremely common and at the same time very troublesome arrhythmia, which is inappropriate sinus tachycardia. This is a sinus tachycardia which is unexplained by physiological demands. You examine the patient, he has a resting sinus rate about 90 beats per minute, but you ask him to walk in the corridor. Then instead of increasing from 90 to 100 or 110, it increases to 140. If he climbs the stairs one flight only, increases to 5. Sometimes the heart rate at rest is very well acceptable, but just moving a little distance will accelerate the heart rate very much. So under these circumstances, if you interrogate the patient more closely, you will find that he has a lot of other symptoms, including undue fatigue, weakness, lightheadedness, or heart racing. Other anxiety manifestations might be present. So even if you treat the sinus, the inappropriate sinus tachycardia, the other manifestation might not disappear. So you need to treat both at the same time. So this is a situation in which the diagnosis should be done by exclusion of more common condition. You need to exclude hyperthyroidism. Check the TSH. If it is normal, check it again. Check it every 6 months, because sometimes hyperthyroidism takes sometimes to appear in the laboratory. Check for the presence of anemia, dehydration, pain, or the use of drugs which accelerate the heart rate. Exclude atrial tachycardia. Make sure it's not sinus tachycardia. Remember when we talked about the p-axis and the importance of excluding atrial tachycardia, because it has a specific line of treatment. Now, sometimes the situation is complicated by the association of POTS, postural orthostatic tachycardia syndrome. You ask the patient to stand up and the heart rate accelerates more than 30 or even 40 beats per minute in the young, below age of 15, in 10 minutes standing. So you cannot exclude orthostatic tachycardia by asking the patient to stand 1 or 2 minutes. He should stand for 10 minutes. So sometimes you get inappropriate sinus tachycardia at rest and orthostatic tachycardia and postural orthostatic tachycardia syndrome when the patient stands for 10 minutes. How you treat? Reassurance is an important point. You need several visits with the cardiologists in order to build a good rapport with the patient. If we trust the patient that this is not going to produce cardiomyopathy, it's not a risky condition, and the treatment is actually very difficult. Exercise training may help, but usually this is unproven. You can use beta blockers or calcium antagonists, but most of the time they are not effective. Class 2B indication, 2A indication is ivabradine, which inhibits the funny current, which we talked about previously when we discussed the heart failure. It's approved for the treatment of heart failure, as we mentioned last lecture, but it's not approved here except as a class 2A, not a class 1 indication. And it's sometimes combined with beta blockers or calcium antagonists. Keep away from sinus node ablation or sinus node modification. Sinus node modification, in contrast to AV nodal ablation, is a very difficult situation. It's very easy to ablate the AV node. It's very difficult to ablate the SA node. The SA node is hidden behind the upper part of the crista terminalis. You can't reach it from the subendocardium. It is anatomically located subepicardial and is penetrated by a large artery, the artery of the SA node, which cools it continuously and makes radiofrequency ablation difficult. And if you ablate it or modify it, then the need for pacemaker would be very high. It's close to the phrenic nerve and produces phrenic nerve paralysis as well. So as you see here, the treatment is not something easy. Various guidelines recommend ivabradine as 2A, and as you see here in the Heart Rhythm Society recommendation, sinus node modification or ablation is class 3, not to do. Now we move to another subject, which is supraventricular tachycardia in adult patients with congenital heart disease. Actually, most of these conditions are having a hemodynamically significant congenital cardiac anomaly, And the tachycardia here is an intra-atrial reentrant tachycardia, very similar to typical or atypical atrial flutter. Sometimes it degenerates or is associated or is followed by atrial fibrillation. And if you have supraventricular tachycardia in patients with Epstein, you have to look into accessory pathway. Sometimes they are located on the left side of the heart, commonly on the right side. Sometimes in corrected transposition, it's located on the left side of the heart. Sometimes they are multiple, and sometimes they are malignant. Consider, this is really important, consider always in congenital heart disease, if you get an arrhythmia, consider the interplay with hemodynamic abnormality or an anatomical defect. So if the patient is getting an atrial septal defect, correct the atrial septal defect before handling the arrhythmia. If the patient is getting pulmonary regurgitation, correct the pulmonary regurgitation before dealing with the ventricular arrhythmia. So the interaction between the hemodynamic disturbance and the arrhythmia is notoriously important in patients with congenital heart disease. No treatment is going to stand the test of time unless you correct the hemodynamic disturbance first, and then you look for the arrhythmia. Probably it will be corrected spontaneously or needs minimal intervention. Class 1 recommendation is to consider hemodynamic abnormalities and correct the hemodynamic abnormalities. Ablation is less successful in these patients because you get a Swiss cheese appearance of the myocardium in these patients. So if you close one channel by ablation, another channel will rise up, and you get a high percentage of failure under these circumstances. So how you treat supraventricular arrhythmia in adults with congenital heart disease? Again, if the patient is unstable hemodynamically, cardioversion or adenosine if possible. If it doesn't work, you go to intravenous beta blockers or intravenous cardiodiazem. If not, then you go to class 3. As you see here, we don't include class 1C because these are patients with structural heart disease, and 1C is contraindicated in patients with structural heart disease. So you move from cardioversion, adenosine to beta blockers and calcium antagonists to class 3. On a chronic basis, assess the hemodynamics, repair the hemodynamic structural abnormality which is present and the structural abnormality. Consider beta blocker of class 3. If you have a Epstein's anomaly, catheter ablation or surgical ablation. Many of these patients after surgery, they have a pacemaker situated in, so overdrive pacing, you can get rid of this situation. So this is an important point which falls in the domain of adult cardiology. Now this is the last question. 22-year-old woman presents to the emergency department with heart rate of 200 per minute, blood pressure on the low blood pressure, 78 over 40 millimeters of mercury. She has 5 months of pregnancy, and she has a past medical history of severe bronchial asthma. She was instructed to do Valsalva maneuver, but supraventricular tachycardia resisted the Valsalva maneuver and continued. She is anxious appearing. So what's the most appropriate next step? Give adenosine, give metoprolol, give diltiazem, give amiodarone or cardiovert. Now, obviously, if the patient is asthmatic, you cannot give adenosine, you cannot give beta blockers. She's hypotensive, so you cannot give diltiazem, and amiodarone is teratogenic and is usually not recommended in pregnancy except under very exceptional circumstances. So the correct treatment here is cardioversion, and this is the subject. So supraventricular tachycardia in pregnancy is common. You have a situation in which there is hypervolemia, increase the cardiac output, increase the atrial stretch. So it paves the way to all kinds of supraventricular tachyarrhythmias. Adverse events have been reported because of placental ischemia from the rapid heart rate. Beta blockers can cause growth retardation, respiratory depression, and fetal hypoglycemia, particularly atenolol, which is a class D for pregnancy. So always to be avoided. If you use beta blockers, you can use them, but keep away from atenolol. Data are limited to small series, and avoid drugs in the first trimester. How you treat supraventricular tachycardia in pregnancy? Vagal maneuvers again work very well, particularly if you allow the patient to lie back and, or on the side to avoid inferior vena cava compression. You can use adenosine. You can cardiovert the patient. There's no contraindication. Pregnancy is not a contraindication to cardioversion, but keep the pedals away from the upper abdomen. Don't allow the lubricant or the to pull on the abdomen and conduct electricity to the uterus. Use the pads away from the uterus and monitor the fetus. If cardioversion didn't work or is not available, you can use intravenous metoprolol or propranolol, but don't use atenolol, as I said. You can use beta calcium antagonists. If nothing works, then you have to go to class 3 antiarrhythmic drugs. Amiodarone is not teratogenic if it's given once or twice intravenously in the acute situation, but it is teratogenic and can produce fetal neurotoxicity as well as hypothyroidism and fetal goiter if it's used long term. But so the answer of the question is cardioversion, which is not contraindicated in pregnancy. Same way, same dose, same approach like in normal non-pregnant individuals. But in chronic therapy, we prefer safe drugs. Digoxin has proved its safety for 250 years now, but it's still not used as a first choice. We use beta blockers, keeping away from atenolol. You can use, if there is no structural heart disease, you can use 1C drugs, flecainide and propafenone. If nothing works, then you can use sotalol or amiodarone. But remember that if chronic use of amiodarone is produces fetal hypothyroidism, goiter, obstructive labor, and neurotoxicity. What about ablation? Usually we succeed in treating these patients chronically by drugs. With ablation, the patient is forced to lie on the back for quite a long time, and this compresses the uterus and prevents the venous return, diminishes the cardiac output, and produces placental ischemia. So usually we keep away from ablation in addition to the effect of radiation, although with a new mapping device you can carry ablation with little radiation or no radiation at all. So this is the important point, is that we prefer the use of drug, but keep away from drugs that have teratogenic or neurotoxicity effect on the fetus. So the summary of this supraventricular tachycardia, as we said, we classify them by only one classification, relates to the position of the P wave relative to the R wave, 3 short RP, 3 long RP, as we mentioned. Acute management, if unstable cardiovert, if stable, use adenosine, move from adenosine to AV nodal blocker drugs. If nothing works, then we can go to class 3. If there is no structural heart disease, we can use 1C drugs. For chronic management, ablation is the first choice. If the patient refuses, we offer him drugs. But the next time we discuss again ablation. Third time we discuss again ablation until he gets convinced with ablation. It doesn't convince, then he can continue with drug, and you can use antiarrhythmic drugs in the order we mentioned. WEW, look for the risky situation in which the RR interval is less than 250 milliseconds. Pre-excited atrial fibrillation should be recognized and should be cardioverted. If you have a handle on butalide or procainamide, you can use it. Not available in Egypt, so we cardioverted this patient. Asymptomatic, you can leave alone unless there is high risk because of the short RR or the accessory pathway refractory period or the job of the patient. Inappropriate sinus tachycardia is a diagnosis of exclusion, hard to treat, keep away from ablation, use drugs in combination. The best is ivabradine. Adult congenital heart disease, consider the anatomical and physiological abnormality, correct them because they are the mediator for supraventricular tachycardia, and in pregnancy use adenosine and verapamil, and in chronic situation use safe drug like digoxin, beta blockers, 1C. If there is no structural heart disease, ablation is a last resort. Avoid amiodarone unless the patient is highly symptomatic and there is no other choice. So thank you very much for watching. and then I will expect your questions to answer them. دكتور محمد ثابت، دكتور احمد شحاته.
ازي حضرتك يا دكتور محمد؟
يا اهلا، ازيك يا احمد؟ في اسئله عندك ولا ناموا؟
لا، في سؤال. في حد بيسأل بيقول في is there any types of supraventricular tachycardia in which termination of pregnancy is a must?
No. No, there is no indication for termination of pregnancy for supraventricular tachycardia based on obstetric situation. Usually drugs fail to abort it. You don't need ablation. You don't need even going to class 3 antiarrhythmic drug. So by itself, it's not an indication for it. If you have supraventricular tachycardia as a part of another congenital anomaly like pulmonary hypertension, so the indication will be pulmonary hypertension or Eisenmenger syndrome, and this is the indication, but not will be the supraventricular tachycardia by itself.
Okay. في سؤال تاني بيقول how to diagnose atrial tachycardia.
How to diagnose atrial tachycardia؟ امال احنا كنا atrial tachycardia معناها ان احنا we have a focus. This focus could be an abnormal automatic focus, or could be a micro re-entry, or could be a triggered activity. So this is the three types. Located somewhere in the atrium, but not in the sinus node. We have a rare syndrome called sinus node re-entry tachycardia. It's probably another automatic atrial tachycardia at the upper part of the crista terminalis. So we localize it. How we localize it? By looking at the P wave in the 12-lead electrocardiogram. In the 12-lead electrocardiogram, look like WBW. We are looking for the accessory approach. Then same rule applies. So if it is negative in E1, it means that the activation is going away from the right atrium, so it's located in the right atrium. Where in the right atrium? The areas of the right atrium which produces the P wave is the superior vena cava, inferior vena cava, coronary sinus, crista terminalis, and the limbus of the fossa ovalis. So we look for this area. The axis of the P wave, the morphology of the P wave, كلهم دول مش sinus, كلهم دول abnormal, help localizing the area. Then we map it by any method of mapping, and then we ablate. So the diagnosis هو ان في P wave rapid heart rate with abnormal axis. So this is how we diagnose that.
في سؤال تاني يا دكتور محمد بيسأل على الرول of anxiolytics in treating inappropriate sinus tachycardia.
The role of anxiolytic in treatment of appropriate sinus tachycardia هي the role of anxiolytic in treating anxiety. طبعا التريتمنت اللي recommended دلوقتي هو talking with the patient, psychotherapy, not to resort to drugs. If you resort to drugs, keep away from the benzos, the benzodiazepine. Benzodiazepine is absolutely damaging to the brain. The benzodiazepine, they can work for acute anxiety and panic attacks, but they cannot be relied upon for treatment chronically. And the word chronically here means 2 to 4 weeks or more. So if you took benzodiazepine for 4 weeks, benzodiazepine, they block the GABA transmitter by opening the chloride channel. And if you use them chronically, they allay the anxiety. That's true. But the problem is that they will let you amnetic, and amnesia, mental destruction, lack of spontaneity, and addiction. So we keep away from that. So what drugs we use? We use the antidepressant. We rely essentially on psychotherapy. If not, then we use the antidepressants. If not, then you refer to the psychiatrist for electroconvulsive therapy or other situations. But usually we try at first non-pharmacological therapy. What is the effect of this on arrhythmia? Nothing. As we said, the treatment of arrhythmia, this is a very complex situation. But one of the things اللي احنا بنقولها للعيانين دول هم ان yes you are tachycardia. Yes, this is not normal. لكن ده عبارة عن condition safe. It might be irritating شوية لكن is safe. The drugs will help you لكن might not help the anxiety associated with it. You can train yourself انك تمشي كل يوم. انك انت تعتقد انك انت ما انتش in danger لان does not produce cardiomyopathy. ليه does not produce cardiomyopathy؟ لان during sleep the heart rate is almost normal. So the average heart rate اقل من 100 وبالتالي ما بيؤديش الى cardiomyopathy. وزي ما قلت ان هو محتاج زياره او 2 أو 3 للكارديولوجيست. ولو شفت السلايد اللي انا حطيتها اول حاجه انك انت you establish confidence between the treating cardiologist and the patient عشان يصدق كلامه. ودي does not come from the first time. Now if you resort to the drug 2A is ivabradine. 2B is combination of ivabradine and the beta blocker or calcium antagonist. Again 2B is calcium antagonist and beta blocker alone. We try all of these things. طبعا في ناس بتsuggest to العيانين دول to ablate the sinus node. We warn against that. Don't ablate the sinus node. أو number 1 it is difficult. Number 2 it's a failure. Number 3 pacemaker will be indicated in a huge number of patients. Number 4 even if you treat the inappropriate sinus tachycardia, the associated manifestations need separate treatment. So here is a situation when you treat the whole patient, not the tachycardia by itself. Most of these patients, the condition stays for 5, 6, 7 years and then goes away. So this should be told to the patient. It allays their anxiety too much and helps them to tolerate the situation. طبعا كل dysautonomia is exhausting thing. Partial orthostatic tachycardia syndrome, inappropriate sinus tachycardia. كل الحاجات دي exhaustive. العيانين دول عندهم multiple complaints. They have fatigue. They move between different drugs. They get addicted to some drugs. So right from the beginning, the treatment map should be clear to the patient, and the treatment algorithm should be discussed repeatedly with them and with the participating treatment doctors منهم السايكاتريست.
في سؤال تاني يا دكتور محمد بيسأل على safety of ivabradine regarding risk of atrial fibrillation.
طبعا small percentage of ivabradine في الترايل بتاعته اللي هي الشيفت ترايل كان producing atrial fibrillation. هو ليه two complications غريبين، الفوسفينز والatrial fibrillation. They shorten the atrial refractory period, so they produce atrial fibrillation. This is I think in that study كان 5% of patients عندهم الحكايه دي. الفوسفينز ده هو انه لما يغمض عينيه يشوف نور او يشوف دواير او يشوف حاجه زي كده. Then the IF channel is also present in the retina. So if you block it, you get this side effect. So we try to keep away من ان هو يبريزنت. طبعا لو الابرادين producing this side effect, it should be stopped and replaced by beta blockers or calcium antagonists or a combination, but not with the ablation of the SANO.
تمام. في سؤال كمان بيقول chronic management of accessory pathway if patient refuse the ablation.
If the patient refuses ablation and the chronic management of the if the accessory pathway دي برضه احنا قلناها. If the accessory pathway conducts anterogradely يعني في دلتا ويف في الالكتروكارديوجرام ده situation. أو if it conducts retrogradely concealed accessory pathway يعني gets supraventricular tachycardia AV re-entry tachycardia لكن البيز لاين الستاندرد اي سي جي الريستنج الكتروكارديوجرام ما فيهاش دلتا ويف. تريتمنت مختلف. نمسك الكومن سيتويشن اللي هو concealed pathway. انت interrupt السيركل anywhere. interrupted in the AV node. beta blockers, calcium antagonists, 1C drug rarely غير كده اهو. يبقى under these circumstances you interrupt the circle وبالتالي لا يمكن هتلف قفلتها في الAV node. دي حاجه. الحاجه الثانيه انك انت suppose that the patient has a delta wave. So this means that ان هو liable ان يجيله atrial fibrillation. الاكسسوري باثواي باي اتسيلف بروديوس atrial fibrillation. لو بصيت لصوابع ايديك كده هون هتلاقي بعض الصوابع عاليه وبعض الصوابع قصيره. So the accessory pathway الفايبرز اللي كونكتد للاتريوم بعضها طويل بعضها قصير. So when the impulse comes from the ventricle it activates the atrium in different points. So as a result of that atrial fibrillation occurs. If atrial fibrillation occurs and the accessory pathway عامل دلتا ويف معناه مقابل ان هو يكوندكت انتروجريدي وبالتالي هي ريسكي. فالعيان لازم يفهم النقطه دي ان هو liable to sudden death because of occurrence of atrial fibrillation. If he refuses to use drugs اللي هي بتبلوك الاكسسوري باثوي you cannot drug انك انت تيوز. Unfortunately الدراجز دي محصوره في كلاس 3 اللي ما فيهاش منهم اميودرم، يعني السوتالول، ابيوتالايد، لوفيتولايد، هم دول الدراجز اللي بتستخدمهم، ودول كارينج ريسك بتاع prolonged QT interval and the need for hospitalization 4 hours in abutolide and 3 days for lofitolide اللي هو اتشال من الاي سي سي جايد لاين. So but the patient لما العيان يرفض حاجه ده مش معناها ان دي نهايه الدنيا. نمره واحد ميك شور هو ليه رافضها؟ انت ليه بترفضها؟ هتلاقيه انه مس انفورم. قالوا له انه في عيانك عنده فنتريكولار تاكيكارديا، عملوا له ابليشن للفنتريكولار تاكيكارديا مات. ده سيتويشن مختلف. هو ما does not understand the risk. هو مش فاهم الديتيلز بتاع الابليشن بروسيدور. هو مش فاهم وهكذا. يعني لازم العيان يبقى ديسكاست. لو فشلت في مره، المره الثانيه نعيد الديسكشن دي مره اخرى. لكن انك انت تجامب وتدي العيان. اذا كان العيان ما عندوش انتروجريدلي كوندكتنج اكسسوري باثوي then giving him an AV nodal blocking drug will be relatively safe. If he conducts anterogradely, then you are in trouble. Next.
بيسأل بيقول how to exclude WBW as the underlying cause of acute SVT.
Acute SVT.
بيقول how to exclude WBW as a cause of acute supraventricular tachycardia.
يعني السوبرا فنتريكولار تاكيكارديا ممكن تكون AV ري انتري تاكيكارديا، واحنا اتكلمنا ان في فرق بين الثلاثه تاكيكارديا. ده السلايد رقم 2 نلاقي فيه QRS نارو at a rate more than 100 بقت سوبرا فنتريكولار تاكيكارديا. ريتروجريد بي ويف بمسافه بين R و P شورت RP، لكن الديستانس دي اكثر من 70 ملي سكند. يعني البي ويف ريتروجريد to the left of the middle line between ال RR والمسافه ما بين البيجيننج بتاع ال RQRS and the P wave اكثر من 70 ملي سكند. Then this will establish almost ان دي supraventricular tachycardia of the AV reentry tachycardia. Then you think ان العيان محتاج ablation and localization. You localize the accessory pathway بالelectrocardiogram. If the patient accepts the possibility of ablation, take him to the AV lab, and then أنا وريتكم صورة للانتروكاردياك electrogram مورية إن الconduction from the atrium through the AV node to the ventricle and then back to activate the coronary sinus اللي فيه موري الديكا الكترود بيوري مكان الايرلي اكتيفيشن. زي ما وريتكم انا صوره الايرلي اكتيفيشن في CS1 and 2 اللي هو الديستال coronary sinus، عرفنا مكانه في الميترال فالف. then we try to ablate the accessory pathway. So that's different steps. First the history. Young individual, rapid tachycardia, ECG, narrow QRS complex, negative P wave in the inferior leads, short RP, distance after 70 millisecond, and then EPS, and then ablation.
تمام. في سؤال كمان role of anticoagulation in SVT.
role of anti طبعا SVT technically المفروض تشمل atrial flutter and atrial fibrillation، بس جرت العاده ان احنا we restrict SVT للثلاثه اللي احنا اتكلمنا عليهم والثلاثه الانيوجوال فورم. لكن atrial flutter, atrial tachycardia, atrial fibrillation needs anticoagulation. If you have SVT without these, there is no indication for anticoagulants because of SVT. طبعا ممكن العيان يبقى عنده indication ثانيه للانتيكواجولانت، واخد بالك؟ لكن في حالات من SVT بتقلب atrial fibrillation، وفي حالات من atrial fibrillation بتقلب SVT. Remember ان هو الميكانيزم ذا سيم. If you have انا وريتكم SVT او atrial tachycardia طالعه من الرايت انفيريور pulmonary vein، هو ده الاوريجين برضه بتاع الاتريال fibrillation. So if you have the patient in the history suggestive ان someone is having a regular palpitation, put the patient on Holter monitor. He might be getting tachycardia induced atrial fibrillation. SVT بتقلب atrial fibrillation. This is paroxysmal atrial fibrillation. Then you apply Shed's mask. If it's indication for anticoagulant, he should be anticoagulated. But SVT on its own, without another indication for anticoagulation, no. After ablation for atrial fibrillation, you might get an ablation lines separated from each other, so the impulse passes between the ablation line and produces atrial flutter or produces supraventricular tachycardia. Under this circumstances, the patient should be anticoagulated because he will get an atrial fibrillation. So we anticoagulate atrial fibrillation, atrial flutter. When we ablate on the left side of the heart, we anticoagulate momentarily, and we ablate if there is tachycardia-induced atrial fibrillation, or if there is an indication the atrial fibrillation or the anticoagulation, the previous thromboembolic accident.
في سؤال تاني بيتكلم if a patient on minoxidil for alopecia and complaining of severe tachycardia in attacks, what's the best treatment line?
Best treatment line Holter monitor. ممكن minoxidil ده عامل sinus tachycardia. We have to know الاريثميا. We have to know الاريثميا. دي سهله. اذا كان بيابلاي الباتش يجيب له تاكيكارديا هولتر مونيتور، او بلاش كده هو يرسم رسم قلب اثناء التاكيكارديا. يعني if it's so frequent انه ابلاي الباتش عشان يطلع الشعر، اذا كان هيطلع الشعر وبعدين ارسم رسم قلب، شوف ممكن تكون ساينس تاكيكارديا. وموست لايكلي انها تكون ساينس تاكيكارديا. لكن قبل كده هو if you find another tachycardia, the treatment will be treatment of that tachycardia. First of all, reconsideration of minoxidil. بص على حاجة تانية نستخدمها بدال.
في سؤال بيسأل في الاتريال fibrillation، بيسأل best heart rate control to reach during rest and exercise in atrial fibrillation.
اوكي، ده atrial fibrillation هي المرة الجاية هنتكلم على هذا الكلام. واخد بالك احنا we know ان احنا في study مورية الفرق بين lenient control and strict control. لكن اللينيانت كنترول ده كان هو 110 فما اكثر، لكن في الاستادي في الواقع كان اغلب العيانين عند 95. We don't allow lenient control. We like for our patients to be at rest في حدود 60 70 and when we exercises في حدود 70 أو 80 90 not more than that. So in a practical way this is the heart rate which is acceptable and if the patient is exercising مش عاوزين نعدي 90. إذا كان هو أترست مش عاوزين نعدي 70. ولكن المرة الجاية هنشرح الديتيل هذا الكلام وهنتكلم على الترايل اللي هي ورت الفرق بين اللينيانت كنترول والستريكت كنترول.
آخر حاجة في دكتور حازم أحمد بيعيد نفس السؤال، مش عارف متهيألي يا دكتور محمد ثابت لو تقدر تأنميوت دكتور محمد يسأل هو بنفسه، اعمل كده.
اوكي.
في حاجة تانية؟
في دكتور حازم عايز يسأل، أنا قريت سؤاله بس هو راجع يسأله مرة تاني، هنخليه يسأله هو بنفسه.
خلاص ماشي.
دكتور محمد مساء الخير.
يا أهلا حبيبي.
تمام الحمد لله. بعد إذن حضرتك إزاي أكسكلود إن عين جاي لي بأكيوت SVT إن يكون الأندرلاين كوز بتاعه هو WBW عشان ما أديش الكونترا إنديكيتد دراجز، لأن كانت حصلت قبل كده والعين ضايع.
ما هو ده اللي احنا قلناه. انا بفكر في الاس بي تي دي هل هي اتريال تاكيكارديا ولا هي اي بي مودر ري انتري تاكيكارديا ولا هي اي بي ري انتري تاكيكارديا. الكلاسيفيكيشن هي ان احنا بنشوف الار بي قد ايه. الاتريال تاكيكارديا الار بي شورت لونج. الاثنين التانيين الار بي يوجوالي شورت. قد ايه شورت؟ 70 هو الرقم اللي احنا بنحفظه. اذا المسافه بين الكيو ار اس البيجيننج بتاعتها والبي ويف اكثر من 70 we think in AV re-entry tachycardia. We prove this by electrophysiology and we treat based on that. لأن first line of treatment is ablation. طبعا لما electrophysiologist بيديتكت الاكسس باثوي حتى لو ما هوش indication for ablation الكاليتي بتقول ما دام انت وصلت وعرفت مكانه ablated. Success 85% of this. ده اذا انت العيان في الاي سي جي بتاعته معاه 5 6 اي سي جي مفيش دلتا ويف بيجيب تاكيكارديا لما ده اكسسوري باثوي. اذا اديت اي دراجز تبلوك الاي في نود العيان مش هيموت. انت ربطت السيركل. العيان بيموت لما يديفلوب اتريال فايبريليشن اور اتريال فلاتر اند كوندكتس انتروجريد. ما دام بيكوندكت انتروجريد دي يبقى لازم الاي سي جي فيه دلتا ويف. هل انا كده جاوبت السؤال ولا ما جاوبتوش؟
طيب هو لو معهوش اي سي جيهات وانا ما اعرفش الهيستوري بتاعه، لو جاي لي مثلا بشغل واكيوت اس في تي، انا هتصرف ازاي؟ او هتصرف عادي ولا انا لازم اكسكلود دبليو بي دبليو الاول؟
شق وبياخد عنده اس في تي. طبعا انت ما يهمكش هو اي بي نودال ري انتري ولا اي بي ري انتري. يو هاف تو كارديوفيرت هيم. بعد ما هو رجع ساينس لوك ات ذا اي سي جي. اللي انت انا سمعت صح العيان انت بتقول شوك صح؟ كارديوفيرت العيان.
ايوه. طيب الفكره هو لو مش شوك ده، لو انا عايزه، عشان انا بتكلم ان هو
لو هو مش شوك
هو اوكي،
هو مش شوك يبقى ادينوزين.
طب الادينوزين مش افيلابل في مصر كتير.
اذا الادينوزين مش افيلابل في مصر وانا عندي
فلو هدي احنا عندنا الكالسيوم الشانل بلوكر
اثناء التاكيكارديا هو مش شوك. ارسم اي سي جي 12 ليد الكتروكارديوجرام هتشوف البي ويف موجوده فين. مسافه بينها وبين البريدنج بتاع الكيو ار اس اكتر من 70 يبقى انت في الغالب ديلينج ويز اي في ري انتري تاكيكارديا في اكسسوري باثوي. العيان ده هو التريتمنت اوف تشويس بتاعته هو ايبيوتولايد او بروكينامايد. دول مش موجودين في مصر. سو شوك ذا بيشنت اذا انت خايف انك انت تديله فيراباميل او بيتا بلوكر او ادينوزين عشان يكون هو
تمام.
شوك هيم. اذا شوك هيم رجع ساينس ريزم. لوك عنده بي دلتا ويف ولا ما عندوش دلتا ويف؟ عنده دلتا ويف يبقى هو لايبل تو فورورد كوندكشن. يبقى في المره دي الحالات دي هي keep away from the beta blocker وادفايس ذا patient for ablation. اذا كان هو ما هواش عنده دلتا ويف يبقى هو concealed retrograde conduction ودي 80% من الحالات. اذا العيان وافق على الابليشن هيبقى ابليشن ده الكرونيك ميجر. اذا مش موافق على الابليشن هتديله اي حاجه تبلوك الاي نود لانك انت عارف انك انت لما تبلوك الاي نود انتربت السيركل وعمره ما هيكوندكت من فوق لتحت الاكسس
نود. تمام. شكرا لحضرتك.
عفوا. اوكي.
في سؤال اخير يا دكتور محمد، اخر سؤال بيقول if long RB and narrow complex QRS it is usually AVRT orthodromic. مش عارف هو عايز يقول ايه.
ده اول تاني السؤال. A long RP tachycardia
and narrow complex QRS
كويس.
كاتب it is usually AVRT orthodromic.
It's usually AVRT. لا دي عادة يا اما اتريال تاكيكارديا يا اما unusual form of AV nodal reentry tachycardia. لكن انها تبقى accessory pathway orthodromic لا دي مش موجوده.
شكرا يا دكتور محمد، تعبنا حضرتك النهارده.
لا اهلا وسهلا. شكرا. نراكم الاسبوع الجاي بقى في اتريال فايبريليشن
ان شاء الله.
شكرا.
دكتور محمد السلام عليكم.
عليكم السلام.
لا اقصد حضرتك لو هي عندنا نارو كومبلكس تاكيكارديا، حضرتك قلت هي نارو كومبلكس تاكيكارديا بس لونج ار بي يعني اكتر من 70 ملي سكند، هل هنا ما فيش؟
ثانيه واحده.
نعم.
لونج ار بي مش معناها اكتر من 70 ملي سكند. لونج ار بي معناها ان البي ويف واقعه في النص اليمين من الار ار انتر.
تمام.
طب
هي لو نارو كومبلكس في خوف ان انا ادي الكالسيوم شانل بلوكر، ما هي نارو كومبلكس يعني هي كده اورثودروميك.
ايوه.
شوك بيشنت دايركتلي يعني واي تو شوك بيشنت اف هيمودايناميك ستيبل.
هو ممكن تكون نارو كومبلكس لكن الاي في نود الاكسسوري باثواي capable of conducting anterograde.
يس.
لو انت عندك اتريال اكتيفيشن طالع من الساينس نود، ومن الساينس نود بيروح للاي في نود وبيروح للاكسسوري باثوي. سبوز الاكسسوري باثوي عند الليفت سايد اوف ذا mitral annulus بعيد، فاغلب الامبلس هتعدي فين؟ هتعدي في الاي في نود، واغلب الفنتريكولار اكتيفيشن هيحصل من ايه؟ من الاي في نود. ايه الكونتريبيوشن بتاع الاكسسوري باثوي؟ مينيمم، وبالتالي الدلتا ويف بتاعته صغيره. لو قست الكيو ار اس كومبلكس ان هو تطلع اقل من 100 ملي سكند، نارو كيو ار اس، قلنا في اكسسوري باثوي كوندكتنج انتروجريد. امتى بقى تعرف ان الاكسسوري باثوي ده هو؟ لو حصل بريماتيور بيت. لو البريماتيور بيت طالعه من قريب من الاكسسوري باثوي مش هتبقى حكمها حكم الساينس، هتعدي من الاكسسوري باثوي، الدلتا ويف تكبر. الالكتروفيسيولوجي بيقيس الليفت اتريم في الحاله دي ونكبر الدلتا ويف ونعرف ان هو قريب من الاكسسوري باثوي. although ان ساينس ريسك كان الدلتا ويف صغيره جدا. فمجرد نارو كيو ار اس كومبلكس مش معناها ان هو 100% انتروجريدي كوندكت. لازم ابص في ال 12 ليد الكتروكارديوجرام بعد ما السوبرا فنتريكولار تاكيكارديا تروح بطريقه او اخرى.
تمام.
خد بالك الادينوسين بريسبتيتس اتريال فايبريليشن، يعني الادينوسين بيبلوك الاي في نود، بيأكت على البيورينيرج ريسبتورز اللي هو الادينوسين A1 ريسبتور، واخد بالك؟ لكن at the same time shortens الاتريال ريفراكتوري بيريود. فاذا ما كنتش عارف ان هو الادينوسين ده سيف ممكن تبقى في اشكال. يعني سبوز انه عنده اكسسوري باثوي انتروجريدي كوندكت وفي الليفت لاترال وول بتاع الميترال انيوس، وبالتالي جيفنج سمول دلتا ويف ما تتشافش او من شافها وانت مش متاكد هي دلتا ويف ولا مش دلتا ويف. والكيو ار اس كومبلكس نارو لما بتدي الادينوسين يبلوك الاي في نود، ممكن اندر ذيس سيركمستانسز ينديوس اتريال فايبريليشن تبقى كوندكتد من الاكسسوري باثوي والعيان يموت.
تمام.
طبعا العيان ما بيموتش وانت قاعد قدامه، العيان بيموت لو انت بتعمل الحكايه دي ولا معكش دي فايبريليتور. لكن افرض عيان جاله فنتريكولار فايبريليشن ما انت هتدي فايبريليت، لكن هو كاري ذا ريسك. اذا مسكت الدي فايبريليتور فانت مسؤول عن الدي فايبريليتور هيعمل ايه اثناء الدي فايبريليشن and for at least 1 week after. يعني انت لما بتدي كارديو اتريال فايبريليشن الامبوليزم ممكن ما يحصلش ديورنج كارديوفيرشن، يحصل بعدها باسبوع. يو ار ريسبونسبل. اوكي؟
اوكي تمام.
تصبح على خير.
ماشي، السلام عليكم. وعليكم السلام.
عليكم السلام.
شكرا دكتور محمد، تعبنا حضرتك، شكرا جزيلا.
شكرا يا حبيبي.
دكتور محمد، واحنا كان معانا دكتوره وفاء العروس بس هي النت عندها بيقطع. هي بتعتذر لحضرتك بس عشان النت عندها بيقطع فيها اضطرت تخرج، بس هي كانت موجوده في اول المحاضره.
طيب سلم لي عليك. عاوزين حاجه ثانيه؟ فيها اي اسئله ثانيه؟
لا تمام، شكرا يا فندم.
شكرا يا فندم.